But really what I want to do today is just give a bit of an overview of what's happened in the management of advanced prostate cancer over the last decade or so. And I think the real take-home message that I could probably tell you up front, and then if you doze off to sleep, it's okay. I think the take-home message is really we've seen some phenomenal changes in managing prostate cancer over the last decade. It's been a very exciting time to be involved in research in prostate cancer. It's been very exciting to see the developments and the changes that we're seeing in how we look after our patients with prostate cancer. And so much so that it's actually become quite complicated to know how best to sequence and use all the different agents that have now become available to us. That's really the summary of what we're going to be talking about tonight. So in fact, I thought the way to do that would actually be to start off with the conclusions, because really these are the key messages, and hopefully through the talk you'll get a clear understanding of all that. One of the first and most important messages is that we're all individuals, and I say that on two levels. The first is from a tumor point of view. Prostate cancer is not one disease. Within prostate cancer there are a number of different situations that pose quite different management problems, and also the person in whom the prostate cancer is occurring is also quite unique. So taking those things into account means that it's very difficult to generalize the management of prostate cancer, and it's also one of the reasons why it's very difficult for you to compare notes with a friend of a friend of a friend who's had a similar experience and why they're on treatment X and why their wife's on treatment Y. Particularly if their wife's on treatment for prostate cancer, you should probably give us a call. The other important thing is that as I said, there's been marked progress. There are a number of options now. Really what we're trying to manage better is the sequencing and timing of how we use the different agents. The other important thing is that we've seen a real shift. Previously, with patients with prostate cancer, there was very little that we would offer patients, and there's quite a nihilistic approach to them. There was a lot of advances and excitement around the management of breast cancer and other more interesting or exciting areas for the media and for pop stars, but very little with regard to prostate cancer. And now I think there's been a real shift to a much more optimistic approach for our patients with prostate cancer. The treatment goals have shifted on a number of occasions, and what that's also done is made it challenging to slot in the research that we've just previously learnt about, because then a new trial comes around or a new treatment comes around, and then we say, oh well, now what is the relevance of this last thing that we've just been doing? So that becomes difficult. The other thing I really wanted to highlight was the importance of clinical trials. Clinical trials of what has made us see the developments that have happened over the last decade or so. So it's important whenever possible to try and give patients the opportunity to participate in clinical trials. The other thing I thought we should talk about is what we're not discussing. So we're not talking about PSA screening, we're not talking about radiotherapy, we're not talking about surgery, androgen deprivation therapy, bone health, the new imaging modalities, sexual health, the importance of managing metabolic disease, looking after the palliative side effect of our patients who are undergoing a serious illness, and also looking at individual patients' cases. Obviously, it's impossible to do that without having all of the information. For those of you sitting here going, well, it'd be great to know what he's actually going to talk about, because that looks like a whole lot of topics. The reason I put that up is because it is impossible to deal with prostate cancer in a 2-hour session, just on the advances in this metastatic disease that I'm going to be talking about, but these are all other important components that each in themselves deserve a 1-hour talk. Shirley, if you want to invite me to, that'd be fine. So those are the things we're not going to talk about. This is to highlight a great philosopher of our time who highlighted that we're all individuals, and I think that's the other important thing to take home from this. Prostate cancer is a very heterogeneous disease. The tumour itself is heterogeneous based on the Gleason score, whether the blood vessels are invaded, whether the margins are clear. There is a whole lot of factors that make one prostate cancer experience completely different to another. That's just within the prostate itself. Then within the metastatic disease, people can have prostate cancer which is just involving the prostate, as opposed to having disease that's involving a number of organs, and it's quite a different disease if there's just 1 or 2 lesions in the bone compared to extensive bone metastases, compared to having the organs involved, or compared to having the lymph nodes involved. So just in that background story, the whole prognosis, the whole treatment option decision pathways are very different. The other thing that we're also learning is that how we find prostate cancer is different. So that with the advancement of some of the imaging modalities that we have, metastatic disease in 2018 is quite a different disease to what metastatic disease was in 2015 and 16, when we didn't have these very sensitive imaging modalities, which have really now upstaged our patients. So previously, those patients we would have thought had no metastatic disease. Now with the very sensitive testing that we have, we can pick up disease that we otherwise would not have known about. So again, just to highlight, this is a unique experience for individuals based on the individual themselves, as well as the individual prostate pathology itself. Prostate cancer is a big problem. 20,000 men were diagnosed in 2011. It's 30% of all new cancer cases in men. Of these, 3,500 patients will die from the disease, and some of them are as young as 45 years old. This is equivalent to the number of people with breast cancer. We just don't get as much noise and things around that, and I think that's an important message, and having groups like this is important in trying to spread the message and the importance of looking after our men with prostate cancer and looking after the support of our men with prostate cancer, and also to encourage more research and investment in doing some of the clinical research that is out there. The good news is, though, that the 5-year survival from 1982 to 87 has gone from 58% to 92%. And this is shown in another slide, that if you were diagnosed with prostate cancer between 1995 and 1999, you had an 83% chance of surviving 5 years. Whereas if you were diagnosed between 2005 and 2009, it's up to 92.9%. And as you can imagine, the data for even more recent diagnoses would be higher. Now, there are a lot of factors that influence that. Some of them is the stage shifting that you'd expect with earlier detection, with PSA screening and those sorts of things. Although, as I said earlier, we are not talking about PSA screening, but those sorts of things will impact on shifting that curve. And the other thing that's obviously doing it is some of the treatments that we're going to be talking about today. This is a slide that I presented in 2007 to talk about the treatment options that we had for our patients. Pretty poor. Couple of drugs, that's all we had. In 2017, that's what the slide looks like, and there's even more. And there's also interrelations between the timing of these different drugs. So really, you don't need to know all of those drugs. I just wanted to highlight the complexity of how it is now to manage these patients. It's important that we also just understand the natural history of prostate cancer and what we're going to be talking about today, what sort of stages we're talking about today. So prostate cancer generally starts off, can be diagnosed at any time along this curve. Often patients are diagnosed with local-only disease, where they're picked up by a PSA or some other screening modality, where there's disease just affecting the prostate, and then treatment with definitive local therapy, such as surgery or radiotherapy, could be considered. For some patients, that's the end of the story. There'll never be a recurrence, there'll never be a problem with the disease again. For other patients, even despite having local therapy, at some stage the PSA may rise, suggesting that there is some residual disease. And if there is residual disease, the standard treatment that we would consider using is to block the testosterone drive by using androgen deprivation therapy. That will work for a period of time, and then there'll be a drop in the PSA, and for some people that will also be the end of the story, not to have a problem again. But for others, despite that, at some point in time, the PSA may start rising again. And this is where we start thinking about all these new complex treatments that we start adding. The focus of the talks that we'll be looking at today is for people with either non-metastatic disease that is asymptomatic, or and that is hormone sensitive, because there's a lot of new treatments in this area. But the bulk of our treatment will be talking about people with castrate-resistant disease, and we'll talk about that in a minute. What is castrate-resistant? What does it mean? Essentially what it means is that prostate cancer is still growing and developing despite the fact that we've removed testosterone. And the testosterone levels are at the levels below the level of detection at a certain amount. And despite that, the tumours are looking for other sources of growth to continue to grow. We know that prostate cancer growth is initially driven by testosterone. So prostate cancer cells will have a testosterone receptor on the outside of the cell. When testosterone lands in that receptor, it will make the tumour grow. So obviously if we take testosterone away, and there are various methods of achieving that, when you take that away, you're taking the drive of the prostate cancer away. And by doing that, you can control the disease for a period of time. After a period of time, in some cases, the prostate cancer will then start using mutations to start saying, well, if I'm not getting testosterone, they look at other methods and other pathways that they can rely on for the cancer cells to survive and continue to grow. And that's where the newer treatments come in. So when we talk about castrate-resistant disease, we're talking about those patients who have had castrate levels of testosterone achieved by however we decide to achieve it, and then the PSA still continues to rise despite not having testosterone driving it. It's always hard to know how to talk about a prostate cancer experience or talk. Should we start off with the very early stage of disease and then move on through the different stages and look at the treatment options? Or do we start off historically as the new drugs developed based on the historical development of a number of new agents? I think it makes more sense to talk about the historical experience, because that really affects how each treatment decision was made down the track. Whenever we look at research in general in cancer, we always test out our new drugs in our patients with the more advanced disease. And that's exactly what happened with prostate cancer. The first trial that really changed the face of prostate cancer was the TAX-327 study. And this study looked at patients who had castrate-resistant disease. So you remember the first curve we talked about, it's those patients on the other side of the curve where hormones had failed and now the disease was growing despite there not being testosterone driving it. And those were the patients who previously had very little options. This study was the most important study on for a number of reasons. Essentially what it did was it gave patients who had become resistant to hormones 3 options with chemotherapy. The patients are randomized to get 3 weekly docetaxel versus weekly docetaxel versus an old standard of drug called mitoxantrone. We're going to see a couple of these curves through the evening. You don't need to understand them in detail, but I'll just explain them to you from an oncologist perspective. We need to see that there's a separation between the curves. And if there is a separation between the curves, it highlights that one treatment is better than the other, and it suggests that this warrants further investigation or potential utilization for our patients. So this was the first study, and you can clearly see that there is a benefit with the one treatment, Taxotere, over the old standard mitoxantrone. Based on that, and some other results that came from the study which showed that there was a better survival, there was a better pain response, there were better PSA responses, and importantly, there was better quality of life. So despite having chemotherapy and the potential side effects of chemotherapy, the patients also got a better quality of life. And that's something that's very important to look at when we're looking at a disease where we can't completely eradicate the tumor, because if you can't eradicate the tumor, you want to make sure that not only are we providing symptomatic and survival benefits, we also want to be sure that we're providing some sort of quality of life benefit as well. And that was what was important with this trial, is it showed that it met all of those criteria. The important thing with chemotherapy, though, is that it's not for everyone. And we need to weigh up the risks versus the benefits, the side effects of the treatment versus the potential benefit. We want to try and select those patients who are most likely to tolerate the treatment, and also to select those patients who are most likely to benefit from the treatment. And the timing of when we start that treatment becomes critical. So the Taxotere trial was the first study that actually showed a survival benefit in patients with metastatic prostate cancer if we intervened with chemotherapy. Aside from that benefit, it was the important moment in changing the enthusiasm and interest in looking after patients with prostate cancer from a research and clinical trial point of view, because suddenly we've seen a positive result and everyone wanted to jump on the bandwagon. Everyone wanted to start testing their new drugs, and it was a fantastic opportunity to now start seeing some progress and development with this group of patients. Now there were questions about what if we combined the chemotherapy with different drugs. Now that we've got a first-line treatment, what options can we look at in the second-line setting? We know that it works in castrate-resistant disease. What if we brought it earlier? What if we brought it to people with very low volume disease? And what if we even started thinking about using this in people with hormone-sensitive disease still? And then even earlier, what if we used it in people just after an operation with only microscopic disease? So all these questions started being asked. We wanted to try and understand how we could best identify patients who are most likely to benefit from treatment. Obviously, these treatments don't work for everyone, and they do come with some toxicity. They do come with some side effects. We've got to try and best define the patients who are most likely to benefit. And there is, it's still a bit, it's still not clear about how to do that, but the research is helping us identify those patients a bit better. So now we know what the best first-line treatment is for prostate cancer once it's become castrate resistant. After a while, that treatment would fail and that treatment would stop working. So it posed a whole lot of questions. Well, what can we use next? And that's what brought on the next trial, which was the cabazitaxel trial, or a drug called Gevtana, which looked at randomizing people who'd previously had Taxotere to either getting cabazitaxel or getting the old standard, you saw it in the previous trial, using mitoxantrone. And again, one of these survival curves also showing a significant, can't see it on that, a significant survival advantage. And it also showed an advantage even in people where the Taxotere hadn't worked very well. So we now have 2 lines of treatment for patients with metastatic disease, whereas a couple of years previously we didn't have any options for these patients. At the same time, another very interesting drug was being looked at, a drug called abiraterone, or Zytiga. And this is a drug that inhibits the conversion of inactive testosterone to active testosterone. Now, this is occurring in 3 main places. The one is in the testes, where you get the bulk of the testosterone produced, but after a period of time, even in the beginning, you'll get a little bit of testosterone produced from the adrenal gland. So what we do with a number of the injections that we use to turn off the testosterone is just block the testicular production of testosterone. There is still a little bit of testosterone that comes through from the adrenal gland. What this agent did was also block the testosterone that was being made from within the tumor itself. So you recall how I talked about the receptor on the outside of the tumor cell. We block the testosterone by various mechanisms, and we can get rid of we can control the disease for a period of time. What some tumors were doing was saying, well, we don't actually care what's happening at a receptor level, we'll make our own testosterone on the inside. And that was not being blocked by the previous treatments that we were using. And that's where abiraterone worked very well, was that it blocked the testosterone from the testes, blocked the testosterone from the adrenal gland, but importantly, also blocked it from being made from within the tumor. So this was very exciting. And again, we always started with these agents in people with more advanced disease. So now we'd established that the timing is all important as well, because we'd established that Taxotere worked in the first line setting, the Gevtana work was being done at the same time, and then we said, well, let's see if abiraterone works after Taxotere. And that's where the first trial was done in this area. So it was called the Cougar 301 study, and we were privileged enough to be involved in that trial here at the SAN. And basically what was done was that showed that half the patients got abiraterone and half the patients got placebo. Sorry, 2-to-1 randomization. Two patients got abiraterone and 1 patient would get placebo. Now you can ask the question, is it ethical to do a placebo-controlled trial in this group of patients? At the time that this study was done, it absolutely was ethical, because the standard of care beyond Taxotere was not to use any active treatment. There weren't really any active treatment options. So what this trial did was gave patients an opportunity to access a drug that was very new and very experimental. We didn't know how good it was going to be or whether it was going to work at all, but it gave patients who didn't have another option an opportunity to access this drug. This study was a very positive study and it showed a significant benefit. So today, doing a study in this setting using a placebo would be unacceptable, because we've moved on from where we were a few years ago with that trial. So a placebo trial, it's important to address this as well, is only relevant when the alternative for a patient going into that trial would be to not have any active treatment. So this trial was ethical then, but couldn't be ethical now. And this is what keeps happening as we get better and better at using more treatments and the goalposts keep changing. It means that what is a feasible study or reasonable study to do changes with time. So this also showed that after docetaxel, this was another option. It's a tablet. As I said to you, it blocks the testosterone conversion from inactive to active, generally very well tolerated, with some minor side effects such as fluid retention and blood pressure problems. So now that it was established that this drug works beyond docetaxel, the question was asked, well, what if we bring it a bit earlier? What if we bring it before docetaxel? And this would only be feasible in patients where they didn't actually have disease that warranted chemotherapy. So it was a rising PSA or low volume disease that didn't need urgent treatment, where you could afford to just sit and watch these patients' disease rather than jumping in with chemotherapy straight away. And so a similar study was done, and again we were fortunate enough to be involved in this trial here, and that looked at giving the abiraterone before chemotherapy. And again, as you can see from these curves, significant advantages over not having any treatment. So what we know from this abiraterone data is that it works after chemotherapy, providing a survival benefit, a quality of life benefit, pain and PSA benefits. We also now know that it works before giving chemotherapy. It's a little tricky in Australia because it's actually only approved for funding by the PBS in people after you've had chemotherapy, based on the original study. And it is also approved for people who are not fit enough to have chemotherapy. So if they're medically declared not to be fit enough for chemotherapy and you're never going to give them chemotherapy, then you can use it in the first line setting. So there's important issues around that. The side effects of Zytiga we talked about, very well tolerated. And now what's becoming controversial is what is the timing? Should we give it before chemotherapy? Should we give it after chemotherapy? And you'll see with the later slide that I'm presenting from data that happened last year in June, we're now even starting to think about using it even earlier. And what happens with that is that all this other data that we've now accumulated says, well, now what does it mean if we give it very early? What does that mean to using it later? What does that mean to the timing of chemotherapy? So you can see how it's becoming more and more complex and individualized to each patient's cancer experience and needs. So another drug I wanted to talk about is a drug called enzalutamide, or Xtandi. This was another oral new targeted hormone treatment that was developed at around the same time as the abiraterone was developed. This drug works slightly differently. Instead of having an enzyme effect, this drug works by blocking the androgen receptor. So you know how we talked about that androgen receptor? This drug sits in that androgen receptor and blocks it. There are other drugs that do that as well. So we're familiar with this drug called bicalutamide or Kosidex, which is an oral anti-androgen agent, and that sits in the receptor. Enzalutamide does it in a much tighter, stronger binding capacity. So it's much more potent than Kosidex in that setting. And effectively what happened with enzalutamide is they did the same things in parallel at roughly the same time that the Cougar data was happening. So while everyone's doing the work on abiraterone, there were people doing work on this drug, enzalutamide as well. And what this drug did was had two different studies, one after using docetaxel, and then another study as well when it worked in the post-docetaxel era to do it before docetaxel. So exactly the same story that happened with abiraterone. And I'll just fly through these slides, but basically confirming the same survival advantage, and then they went and did it before chemotherapy with the PREVAIL study, which is a study that we were involved in, and this data has recently been presented at the American Society meeting, showing significant survival advantages as well. As far as side effects of the Xtandi or enzalutamide are concerned, again, oral agent, not a chemotherapy drug, very well tolerated. The main side effects with this treatment is that it does cause a bit more in the way of fatigue. And there can be quite significant fatigue with this. I just want to reflect back on one of the other side effects with the abiraterone. Abiraterone, because of its impact on the adrenal cortex, on the adrenal gland, it does actually require the co-administration of prednisone or dexamethasone, of using a steroid. And that's one of the issues and difficulties. Although the abiraterone itself is very well tolerated, the addition of dexamethasone or prednisone or steroids has an impact, because that in itself can cause some side effects. So now we have two oral agents that are available, and we need to make a choice when we're sitting with our patient. Are we going to go down the abiraterone arm? Are we going to go down the Xtandi arm? And are we going to do it before or after chemotherapy? And there are a few factors that we use to try and help guide us with that. So similar to the abiraterone data, we know that Xtandi or enzalutamide works post-chemotherapy, again with survival, quality of life, PSA and pain benefits. We know that there's a benefit before chemotherapy. It's got a similar approval program in Australia on the PBS, where it will be funded by the government after you've had docetaxel, or for people who are not suitable for docetaxel. And then we've got to talk about the sequencing again. How do we pick which agent to use and when do we use it, and then you've got to weigh up in which patient you think it's better to use abiraterone versus enzalutamide. This slide really just highlights the 4 main papers that we've talked about, all showing a survival benefit to different degrees. Okay, so here's the elephant in the room. I know you're all thinking, okay, well, that's great. You're giving me all these options. We come to the oncologist and say, well, what must I do? And it is a very controversial and difficult area. And this is one of the things that we do in our consultation, is weigh up the pros and cons of the different options, taking into account the timing of the nature of the disease and how things are progressing, and the side effect profile as to whether we're going to use one drug before or after chemotherapy, and what our whole plan is along the sequence of treatment options for our patients. It's a good place to be, that we actually are confused for choice, because there are so many things that we can do in this situation. So in 2018, we have many choices, and we try and make these decisions based on the biology of the disease, patient factors, some of the toxicity issues that patients are more likely to accept than others. The sequencing is becoming important. And then from a government point of view, this has a major cost implication, because the good news is that patients are surviving much longer with these agents, and they're going to be on these agents for a long time, and they're expensive drugs. On average, the drugs are between $4,000 and $6,000 a month. So it's a lot of money that someone has to cough up for, and that's why it's important that we've got ways of trying to best select the patients who are going to most likely benefit from one agent over the other. Chris Sweeney is an oncologist who worked in Australia for a period of time, and he wrote probably the most important oncology paper in prostate cancer, which was published about 2 years ago, looking at giving chemotherapy up front. So what they did was they said, we know that chemotherapy works in the advanced setting. When people have got metastatic disease up front, what is the role for giving chemotherapy at the same time of giving hormone therapy? Using the advantage that we're going to get rid of some of those cells that are driven by hormones, but we also know that some of the cells are resistant to hormones and will respond to chemotherapy. So if we combine the two together, can we get a better outcome? So half the patients got standard hormone therapy, and the other half of patients got chemotherapy plus hormone therapy. And this really had a dramatic result, particularly for patients who had high volume disease. If you had low volume disease, the benefit of this treatment was very small. If you had high volume disease, the benefit was much greater, with significant advantages for those patients. Now, high volume disease is defined as having more than 4 metastases on a bone scan, or evidence of metastases in the liver or the lymph nodes. This treatment was just 6 doses of chemotherapy, and it really changed the way we manage upfront hormone-sensitive disease. In fact, this data was presented at the American Society meeting at the plenary session over the weekend. By the time everyone got back from America at that meeting, the following week, everyone had taken on this data. It was so convincing and profound and important that there were just no questions. We all just started prescribing that straight after.
Gavin,
Yeah.
I had that.
Right.
And I'm now in my 14th year.
Excellent.
So it was low cancer.
Yes.
But it was growing after the operation. I had the chemotherapy about a month after the operation.
Right.
And then it appeared not to work.
Yeah.
And my PSA started to rise, and I went on hormone therapy, and I'm on a 12-month review with my doctor, 12-month PSA, and my last PSA was less than 0.01.
Excellent. It's good to hear. So, look, I think this is very important data. It really has changed the way we look after patients with that disease. And the other thing that really has happened as well on top of this in the last 6 months is that at the next American Society meeting, the Latitude trial, which was another study looking at a similar group of patients, instead of using chemotherapy, has slotted in abiraterone up front. And again, a similar survival advantage has been seen. Now, this is not approved in Australia at this stage and is currently going through the approval process. But again, to highlight the rapid progress of what's happening in this space. So there's a whole lot of key questions now. So if we've got patients with hormone-sensitive disease, local therapy, using blocking of testosterone? Should we be adding chemotherapy at the start of androgen deprivation therapy? How can we best select the patients who are most likely to benefit from chemotherapy addition to their hormone therapy? What happens if patients' disease becomes castrate resistant? Can we use the drugs like abiraterone and enzalutamide up front, or should we be using chemotherapy first? If we use chemotherapy first, should we use Abi or Enza second? Or if we use Abi and Enza first, is there a role for chemotherapy afterwards? And what are the other things that are happening beyond that space? So it's becoming very exciting. There's a lot of different options available. I really just try and always find a way of putting the slide into my talk. I just think it's a great slide. So I thought I'd say looking into the future of prostate cancer. But there is a lot of stuff that's happening in prostate cancer, and in the next few years, more and more of these treatments are going to become available. There's a lot of excitement around immunotherapy, trying to have a better genetic profile of the tumor to try and better identify who's likely to benefit from which treatment. The PARP inhibitors are becoming a useful agent in a very select group of patients who have a particular mutation. And then there's a bit of work now looking at PSMA lutetium for people with more advanced disease. Now this works in an interesting way. We know that prostate cancer cells secrete this protein called PSMA, and we can label PSMA to this radioactive isotope called lutetium, which is labeled to this protein. This protein seeks out wherever there's PSMA in the bloodstream, in the body, and then will deliver effectively the lutetium to that spot. And so you can selectively deliver a radiopharmaceutical agent to a patient with metastatic disease that's progressed through the usual lines of treatment. This is currently still in the experimental phase, I would say, but there's been quite a bit of research showing that there is some benefits for it, and in selective patients it's something certainly worth considering. So I think in summary, this is a rapidly evolving space. The goalposts do keep changing. We know that docetaxel is a first-line treatment option that is a very established therapy option, but there is some work looking at giving drugs before and after that. How do we best choose those? Hormone-sensitive disease has become an exciting new treatment option with using both chemotherapy and now with the latest data, maybe abiraterone as well. I have barely mentioned, but I just don't want to ignore the importance of supportive therapy. And when I say that, that's not just looking after the bone health, looking after the pain, looking after the urologic symptoms, the sexual function, all of those things. Also the psychological support, and these sorts of meetings and the prostate support group is very valuable in achieving that. And there's a lot of work that Shirley and the team here do to try and make that experience better for our patients. So going back to the conclusions that we talked about in the beginning, I hope you will all feel that I've expressed enough that we're all individuals and each person's cancer experience is very different based on biology and the individual patient. We've seen a lot of progress. We've got a lot of options. Timing and sequencing is becoming the real critical discussion within the patient consultation. I think we should be optimistic about how we're looking after our patients with prostate cancer, and it's good that the goalposts keep changing. It makes the decisions more challenging, but it's a good thing. And all of this is achieved through clinical research, and there's a number of clinical trials happening here and elsewhere that most oncologists would be familiar with, that they can move patients around to get access to those trials, which are important. And I'll just finish off. There have been a few leaps of faith taken over the years, but I think you'd have to agree that there has been some progress. And I'll stop there and take a few questions.
Yeah. Where the bicalutamide
fits into all of that. So bicalutamide, so the time that you'd use bicalutamide is in the first bit of androgen deprivation therapy. It's a good opportunity to talk about how androgen deprivation therapy works. So basically, the testes gets a message from the pituitary gland to say, produce testosterone. Now, we can block that by using two types of drugs. One that turn the androgen, it's the pituitary gland off, and so that's a drug called an LHRH antagonist. It antagonizes the LHRH production of testosterone, so it just turns it off straight away. And that is a new drug called degarelix. If you use the LHRH agonists, which are the bulk of the other drugs that we use, so the Zoladex, Lucrin, Eligard, those sorts of agents, what they actually do before they work is they actually stimulate the pituitary to send a message to the testes to produce testosterone. So you actually can get a flare, you can get a little bit more testosterone being produced, and that testosterone that's being produced then goes to the pituitary and says, there's enough testosterone, stop working. So it turns it off, but it turns it off at about 10 days to 2 weeks. So in that situation, we would use bicalutamide first, because we want the bicalutamide to sit in the receptor and block the receptor, so that when you get the flare, when you get the surge of testosterone, those receptors are not looking for more testosterone and then can cause a flare of the symptoms. So if you've got disease in the bones, it can make the bones worse. If you've got disease in the prostate, it can swell the prostate. So you use that first to block that. So that's the one place it's used. The other place it's used is that for some patients with more advanced disease, we don't want to just rely on stopping the testosterone from the testes. You also want to block the adrenal testosterone. So we do that by using that combination. So in some situations, we'd use the combination for even beyond the 2 or 4 week period. And if you have got that with patients, there's an interesting phenomenon called the anti-androgen withdrawal. What you do is, if people have been on the injection and the Cosidex for a period of time, after a while, the receptor actually uses the Cosidex, the bicalutamide, as if it's testosterone. So the receptor mutates, and it says, okay, well, I'll actually use the Cosidex as if it's testosterone. And so one of the strategies that we use is to actually stop the Cosidex, or stop the bicalutamide. So you stop the anti-androgen, it's called an anti-androgen withdrawal, and if you do that in about 10 or 15% of patients, they'll get a further response. So that's where bicalutamide fits into the whole thing.
Well, I'm in the androgen deprivation. Well, I've been on it for 12, 18 months.
Right.
But the thing I'd like to know is, where do we start these therapies you're talking about? My GP says, keep coming along, gives me the lutes, and away I go for another 3 months.
So it is possible that people stay in this space indefinitely. So it depends. It's impossible for me to say on an individual case, but it depending on the biology of the disease, depending on your response to hormone therapy, and depending on where the disease has moved to, for some patients, all they ever need is androgen deprivation therapy and never get beyond this. So the disease can be stopped at anywhere along this continuum, depending on the nature of the disease. But I'm sure there'll be someone who's looking after you from a systemic point of view to say, we're looking to see what the PSA is doing, looking at scans to see, is this staying controlled? So if it's staying controlled with the androgen deprivation therapy, that's all the patient needs. Now, obviously, it's a good segue into talking about the importance of looking after people on androgen deprivation therapy. So although we can look after the prostate cancer side of things by staying on it indefinitely, there are some long-term consequences of being on androgen deprivation therapy. So the bone health is very important. So it's important to be exercising, to be on calcium and vitamin D, and to do some things to build the bones up and to monitor the bone density. It's important to look after the heart, and diabetes and some of the other symptoms that you can get from long-term androgen deprivation therapy. And it's a very important opportunity to plug the importance of exercise. Exercise has big impacts on your cardiovascular health, obviously, your bone health, but there's also more and more research now showing that exercise has an impact on cancer outcomes. So there's a lot of benefit in exercise. Good. So one of the things, so there's, as I said, there's more and more research about the benefits of exercise, and we're in the process of developing a gym downstairs and setting up exercise classes here at the SAN with an exercise physiologist, probably initially having separate men and women's classes, but hopefully get it to the point where we can do this on a very regular basis. It'll probably start out as a weekly thing, but depending on interest and involvement on patients, we will hopefully extend that. And there's, as I said, there's a lot of work now showing the importance of this. As Shirley said, as a show of hands, would there be an interest here in in people participating in exercise classes?
No lycra required. So you don't.
Oh, no lycra? Would you get more or less if we do
I was
lycra?
going to say, would you like lycra?
Okay, those with lycra. Yeah, you see everyone. All right.
Yeah, and we're not talking about massive gym work.
Yeah.
So we're talking about a form of exercise that will help with this bone health. So
Yeah.
Yeah.
And walking, the Cancer Council has come up with the consensus statement on exercise, and the amount of exercise that actually needs to be done is quite significant. So the research has shown that you probably need to do about a 40-minute walk 4 or 5 times a week. So it's a big deal, and it's a walk where you get a sweat. So I think that's important to do.
And that's there and back. It's not continually in the
Yes,
same direction.
yes, that's right. Yeah.
Gavin, just on the exercise part, is it that the exercise reduces the side effects, or does it make the drugs or the various drugs work better? Has there been any sort of clinical trials?
So it does a few things. Firstly, from a side effect point of view and tolerability of treatment in general. So we know this in a lot of treatment groups. So in breast cancer and colon cancer as well, exercise makes patients tolerate chemotherapy better. And we're actually involved in a trial now at the moment looking at that for patients with colorectal cancer, where people are randomized into 2 groups, because it's all very well to say exercise. What does that actually mean? And that's why the Cancer Council has actually tried to give very clear instructions about that. But one of the exercise trials looks at saying to people, do exercise, as most of us do, say do exercise, and then you go and interpret that how you want, or do a proper exercise program where you meet with an exercise physiologist, you've got commitments and you've got to do X, Y, and Z to see the difference in outcomes. And it does show in general that the more controlled, prescribed, proper exercise you do, it will have an impact on your tolerability of treatment. But now there's actually more and more data in a number of tumour groups, including breast, including prostate, showing that there is actually a survival advantage from a cancer point of view. And the
making the drugs work better.
Not only the drugs, making your body work better against the cancer. So we can't tell you whether it's the drugs working, the overall impact, whether it's making the drugs work better or whether it's your body working better, the net effect that there's a survival advantage. There were some cynics in the crowd when the data was first presented saying that if this was something that we could put in a bottle, and the survival advantage that you could put in a bottle and have it made by a pharmaceutical company, we could charge $100,000 for it a year. So in fact, what I did as a bit of a joke, some of my patients here may have seen it, I got my pharmacist to give me a couple of bottles of normal tablets, empty bottles, and I put a prescription on it saying exercise 3 or 4 times a week, and I'd give them that bottle to see if they'd actually see if it improved the compliance.
Just a quick question, Gavin, with respect to the exercise. Is there in prostate cancer a recommendation for a component of resistance exercise as well as the walking?
Yes. In that consensus statement, there was also 2 days of specific resistance training that was required. So resistance training is important. And there's a lot of places, around where there are people who are exercise physiologists or various people who've got an interest in this who are doing cancer-specific exercise training. And I think that's becoming more and more important. And
Support you a little bit on what you were saying about the exercise. We walk for 50 minutes about 5 days a week, and we've done it for about 10 years. Sometimes it's really quite difficult to keep walking with the pain in the legs.
yeah.
If you just walk through it for about 15 minutes, it sets you up for the rest of the day. And so
Yeah.
I can absolutely support what you say.
Yeah.
So the Cancer Council will be running this enriching program here in May, and they do teach in that program resistance exercise with either a TheraBand or a gym stick. So the TheraBands are available all over the place, different, the stretchy things, but they actually teach people how to do that even sitting in a chair. So theoretically you could do that resistance exercise sitting watching television if you felt like it.
Yeah.
Not suggesting that actually, but don't make it difficult for yourselves, that's what I'm saying.
Just further for you, Shirley, Graham and I did that exercise program with the Cancer Council, and it's really, really good. Yeah, excellent. And they do talk about nutrition as well. Yeah.
Just in regard to diet and the intake of sugars, how does the tumour interpret sugars?
So there has been a lot of noise, I think, in the internet about sugar-free diets and sugars feeding cancer, and there's a lot of interest in that. I'm not sure exactly where it all comes from. The way that cancers grow is very complicated, and although glucose is one part of the pathway that they may potentially use, there has been this sort of promotion of having completely sugar-free diets to starve the cancer. I don't know that there's a lot of evidence to support that approach. There's a lot of conflicts and controversies around that. I suppose one of the first questions would be that if that were completely true, then every diabetic who would have a high blood sugar level should be riddled with cancer, and that's not the case. But there is evidence to show that being overweight and obesity and those sorts of things have a negative impact on cancer outcomes. So I'm not sure that you need to be on a sugar-free diet, but people do need to be on diets where they are maintaining the optimal body weight, because that does improve cancer outcomes. And minimising sugar as part of that is one component of, you know, a normal dietary, good balanced diet, so that you're at the stage where, you know, people are at a normal body weight rather than being overweight, because there are some implications from a cancer outcome with being overweight. One of the things that's also useful, I think, is often to talk to a dietitian who has a particular interest from a cancer perspective in what you can do to try and help with that.